or do it that way, and then go back into the share. Okay, thanks for that. Okay. Right, so now I'm recording and we're on. All right, so the muscle structures around the back of the shoulder, the anatomical structures are the supraspinatus, as you can see, the subscapularis, the infraspinatus, and the teres minor, which is that little muscle there. You'll find that the teres minor and the infraspinatus are the ones that most people have issues with when they have scapular problems. And you know that the couple of needles we looked at the other day reflect that, but we'll go through that properly later on. Then we have another structure called the rotator cuff tendon, and that is at the superior aspect of the shoulder, and it connects to the clavicle and the whole rotator cuff. Okay. The rotator cuff tendon is sort of holds the whole shoulder joint together, and it facilitates the movement. So the tendons are connected to the deltoid, the supraspinatus, the subscapularis, the infraspinatus, and the teres minor. So there are 5 major muscle structures connected to the rotator cuff, all classified under rotator cuff tendon. So then we have the subacromial space, and that's where the bursa sits. As you can see, the bursa, that's where the bursa is, and that's why you can figure out why the bursa gets inflamed so quickly. The ligaments hold the clavicle to the shoulder joint, because the clavicle is not attached to the physical structure. It's not a bony structure that connects from a bony structure to bony structure. It's held together with ligaments. So it's very delicate, and it breaks very quickly. And as you can see, these are the major structures that have a tendency to rupture or be inflamed. And then that's where most clients, when they come in, will have issues. So for you, it's not necessary to identify which ligament, even though some of the tests that you're going to perform will come close to identifying with them, but you just need to know what they are and where they are. The long head of the bicep is because the bicep has 2 tendons. The long head is on the lateral aspect of the shoulder, or anterior lateral aspect of the shoulder, and the short head inserts into the structure just below the clavicle. And as you can see, this ligament here goes over the ligament that comes from the breast area, the chest area. And that's why when we needle here, lung 1, lung 2, that's why it's so effective for the short head. But also the short head is very difficult to see if it is ruptured or injured, because it sits over the other ligament coming from the major and minor muscles from the chest. The red flags: deformity or swelling, pain in rotation, pain when the client can't lift his arm or he can't use his arm, sensory and motor deficit, loss of sensation of voluntary movements. So they're all red flags to the shoulder. Pulmonary and vascular compromise. So we've got the shoulder that it's ruptured or broken, and it's compressing onto the rib cage. It's possibly broken, probably ribs 1 and 2, and they're impacting on the lungs when he breathes. So these are just a guide. So it's really not a guide. It's not really appropriate for the modern man or modern woman, because we're far more physical, and we're fitter than the previous generation. But all these key indicators are valid as far as trying to figure out what's going on, but they're not a very good guideline. So more than 35 years, possibly will be an RC involvement, right? That's just very generalized, but it helps you to understand how to ask the questions, how to perform a subjective assessment based on their age. Okay, so the subjective assessment, the major complaint, signs and symptoms, previous history, previous treatment. So that's the most important things that you're going to go down to, the first questions you're going to ask in trying to assess what is going on with the shoulder and how the shoulder is compromised. PQRST is provocation, quality, region, radiation, severity, and timing. So these are all the questions that you'll be looking at asking. What happened? How was the injury? How did you injure yourself? What's the quality of pain? Where is the area where the pain is? Can you give me an indication of how strong the pain is? And when is the pain? Is the pain in the morning when you wake up? Does it feel better during the day with movement? Does it feel worse? Is it worse at night time? Does it disturb your sleep? So these are all questions that you'll be asking to understand what's going on with the pain. So the mechanism of injury, if you fall onto the point of the shoulder, it's most probably the AC joint. If you do an adduction external rotation, there's usually a dislocation of the RC joint. And headway is the brachial plexus. Okay, that's traction. Subjective assessment. Pain location. Above the shoulder joint is an AC joint. Upper armal deltoid is the RC joint. Anterior upper arm is the biceps or tendon. Below elbow is shooting pain. There's a nerve in the neck, so the nerves are compromised in the neck, and it'll give you a shooting pain down the arm. Night pain, RC disorders. Okay, we're going to stop there, and we're going to ask you if you understand what's going on. Do you have any questions? Any questions? No? No, it's all good. You understand? It's just information, just layers of information that you need to know. Buongiorno, I'm online. Okay. Objective assessment. So you're looking at the shoulder and you're looking for you're comparing the two shoulders. You stand from behind or in front of your client, and you're looking for a symmetry and deformation. You're looking for a dislocation. You're going to think about, oh, is this a deformity because there's a fracture, or is there a dislocation? You're looking for muscle wasting, which is due to a nerve injury or a tear in the RC joint. Bruising, that could indicate a fracture, a dislocation or a fracture. The bruising is a hematoma. That means the muscle structure is being torn, or the bony structure is broken and it is impacted on some of the vessels. Could be lots of reasons why there's bruising. Scars, which will indicate any previous injury, surgery, or surgery history. So here are the red flags. You can see in the first picture on the left, there's a definite fracture there. You can see that. There's a dislocation, possibly, or a fracture. Same here and same there. So these are the red flags. When you see this, this is the acromion. It's possibly dislocated or fractured. So you need to refer those. These are some more red flags. This is a torn bicep. This is also a torn bicep ligament. And that happens quite often. You know, that ball is an indication that the ligament is torn. So this next frame here, this is a signs and symptoms of a shoulder fracture. So severe shoulder pain, swelling, tenderness to touch, deformity or a bump at the site of the fracture, discoloration around the upper arm, inability to normally move the arm without pain. So you're going to just be gentle with the tests, as we talked about the other day. We're doing tests on students that don't have issues. They don't have a pathology of the shoulder or whatever. So this flexibility is great. But when you come across somebody like this, you need to be very careful how you perform those tests, if there's a need to have a test at all. Signs and symptoms of an RC tear. Pain at rest at night, particularly if lying on the affected shoulder. Pain when lifting and lowering your arm with a specific movement. Weakness when lifting or rotating your arm. Crepitus or crackling sensation when moving shoulder in a certain position. So whenever they're rotating or slightly adjusting the shoulder, or when they're trying to move the shoulder blade, there's pain, usually through rotation or adduction. Objective assessments. The SC joint or the clavicular and AC joint, tenderness at the prominence. That's what you need to be considering when you're looking for it, when you're feeling. Greater tuberosity, local tenderness, and which could indicate a fracture. Long head of the bicep, local tenderness, on the bicipital groove. Spine of the scapula, local tenderness and fracture. You all know where those points are on the arm and shoulder? No. Which one don't you know, Andrea?
I don't know the greater tuberosity or the bicipital groove.
The bicipital groove. So the bicipital groove is a little groove as it comes down the lateral aspect. Can you see me? Yep. Just there. That's the bicipital groove. And in the bicipital groove, you'll find that most probably is where the let me see if I can get a photograph for you. Okay. So you can see that.
Mm-hmm.
So the bicipital groove is here. Can you see that?
Yep.
Cool. Right. Anybody else? No. Cool. They're just, if you don't know the names, you know what a greater tuberosity is, right? Greater tuberosity is the head of the here, just there, there's the head of the joint. Anywhere else you're not quite sure? Do you know what the spine of the scapula is? The spine of the scapula that's the spine there, that ridge there. Okay. So palpation. How to ascertain what's going on. The areas that you'll be able to palpate, not many. It's the SC joint, the clavicle, the AC joint, and the greater tuberosity, which we looked at before. So when you palpate, as you can see here, we're putting the hand on the shoulder because we're looking at identifying any movements of the joint. So we have the fingers as we stand with, as he is from behind, you can see the fingers are roughly in the area of the muscles and tendons we're looking at, trying to figure out which one is the problem. So you can see that. This one's here, the anterior. This one's sitting on where the long head and the long head comes out. This one here is where the short head here. These two are about the chest area, just to see what's not working properly, where there's inflammation, what pops up, what doesn't move, as we rotate the arm. So we're supporting the arm, we're doing some gentle movements with the arm, and we're trying to ascertain what's going on and where there's pain. Right? So the palpation continues, as you can see. I just mentioned to you about the fingers, where we're placing the fingers, and we're trying to ascertain where this muscle structure is. Now, this is a physio. This is what a physio will be doing. Not necessarily is this what you will be doing as an acupuncturist. Yeah, this is from a physio perspective. I don't know many acupuncturists who can do that. And I don't know many acupuncturists who have got time to do that because it's not the scope of practice. The scope of practice is inflammation and pain. Now, sure, we can identify where the muscle structure is that we're looking at resolving. Just give me a second, please. Sorry about that. Functioning clinic. Okay. So the objective assessment. So we're looking for range of movement. So when there's a limited active or full passive, it's an RC joint disorder. Painful arch that we looked at, it's an RC joint disorder. With the range of motion, compromised range of motion or passive range of motion, when they're not able to complete the test, we're looking at frozen shoulder or instability of the shoulder joint. The range of motions are here. You'll need to know those range of motions. Because once we go past the range of motion, either in the initial stage or the end stage of the range of motion, there won't be any pain. So the pain is quite indicative. So in the flexion, the pain motion is between 150 and 180, and the extension between 45 and 60, adduction between 150 and 180, and so on. So there you'll need to know those to be able to ascertain if there's any pain or any joint issue or muscular issue. So here, the physio is showing you how to assess the range of motion in a normal flexion. As you can see, most of them don't have that little machine there measuring the range of motion, but this is just an instructional video. So it's just a guide. So you know where the 90 degrees is there. So that's here. So he's looking at 150 to 180 to ascertain if there's any issues with that particular joint. Okay. So he's looking at testing the acromion. So the range of motion, ask the patient to raise their arms forward until you're pointing upwards in the ceiling, and that's 180. And then you're going to ask them to come down to 150 whilst you're supporting. The range of motion for the extension, as you can see, is quite limited. It's only between 45 and 60. Most people are not as flexible as some of the students. I saw you the other day. You guys are quite flexible. Most people aren't as flexible. So the extension is very small. It's a small area, 15 degrees. It's not much. Okay. So you're going to ask your patients to stretch the arm out behind you, and then you're going to assess the range of motion. Range of motion for abduction. Again, the range of motion is 150 to 180. So it's a seated exam. So you're going to ask your clients to be seated, and you're going to go from behind to assess the abduction. And we're looking at the posterior acromion process, so from behind the shoulder, and the movable arm along the shaft of the lateral humerus. The range of motion, you ask the patient to raise the arms above the sides in an arc motion until the hands reach above the head. So it's an extension of the painful arch, and then you perform the test. Shoulder, the range of motion for adduction. So this is similar to the Hawkins test, but all the tests that we did when we came across like that. But you'll set up the shoulder, and you're looking for a range of motion at 135 degrees, which is quite precise, but that's easy to find. You know what 180 looks like, and you just go back from there. It's a seated exam. The therapist is from behind supporting the shoulder, and the shoulder is level, the elbow is level with the shoulder, so you can then perform the test. So to perform the test, you're going to ask the patient to keep the arm straight in front of the body, and then bend the arm back like that. Range of motion for internal rotation. So internal rotation is when the arm comes towards the body, towards the midline. It's a seated exam. As you can see, the therapist is going to be moving the client's hand and holding it in a fixed position. And we're looking for between 70 and 90 as the range of motions. Again, it's quite a small movement. So you're going to ask the client to keep the arm straight and across the body in the opposite side. So the hand's going to reach across to the opposite side of the tummy, and then you're going to perform the range of motion by opening and closing the arm. External rotation between 80 and 90. You can see that the hand is set up almost at 90 degrees and almost in front of the body at 90 degrees. And your therapist is going to be on the side, so you can see the level of the part. So the forearm is level, it stays level. That means the shoulder is relaxed. And then you perform the test. Again, you're going to ask your clients to flex at 90 degrees and then open the arms up to see what the range of motion and what the arc is and where's the pain. So you can see 80 to 90 degrees. So that is almost 90 degrees. With the start point, the fist was here where the arrow is, and it opens up to there. That's a 90 degrees arc. Apley scratch test, which you looked at, which we didn't look at, but it's quite an effective one. It's not one that's used most often because most people aren't flexible anyway. You'll probably find that most people with the Apley scratch test, their hand will struggle to reach past the lumbar area. Yeah, so it's a difficult one. It's great to compare when you're comparing both arms. You can ascertain what's going on, but it's more to do with the muscles in the cervical spine. But it's a good test. So as you can see, there's the test. It's quite nobody can do it. I don't know many people who can do that. I don't know if you guys can. I don't know many people who can do that either. A yoga instructor might be able to get there, but I don't know many who can do that. Painful arch is far more effective. As you can see, the painful arch is between 60 and 120. So there's 60 and there's 120. So that's the arc we're looking for where the pain is. And you can see that it's looking at the subchrominal bursitis or rotator cuff tendinopathy or full thickness of the rotator cuff tears. So what does that mean is the whole cuff is, or one part of the cuff is completely torn all the way through. Internal rotation, it's a resisted test, resistal external internal rotation. You can see where the client sits and where the patient and the therapist sits. For example, we're looking at external rotation. The therapist will be supporting the elbow and placing resistance on the wrist area, and you're going to ask the client to externally rotate. Another test for that is you stand in front of your client, you've got both hands forward, and you're looking to compare the two shoulders. So the therapist stands in front, places their hands behind each closed fist, and you're going to ask the client to externally rotate both arms together to compare. And here's the internal rotation, supporting the elbow in a fixed position. The therapist stands on the side, the hands on the inside of the wrist, and you're asking for internal rotation. Same thing with the last frame here. The therapist is placing he's placed his hand in a fixed position, and you're going to ask your client to press into the hands. That's quite difficult because most therapists wouldn't be able to hold that. Special tests. Where the special tests, what they're looking for. This is going to help you in your assignment, in your test. So the Gerber's liftoff test, which we looked at, is subscapularis. The Speeds test is the bicep tendon. Fourcan test is supraspinatus. Hawkins test or Mears test is shoulder impingement. And then we have the infraspinatus test for the teres minor and the apprehension test for the joint instability. They were all listed and we all did those. So the Gerber's lift-off test, speed test, full count test. So these are we're going to go through and see how they impact on the particular joint and what they're assessing. So the Gerber's lift-off test for a client. So when you place the hand behind and you place the resistance and you ask your client to lift the hand off the back, we're looking for the insertion of the lesser tubercle humerus. So we're looking for the insertion there. That particular area there is where we're looking for pain. And what it does, it internally rotates the arm. So the arm is internally rotated, and this is where the pain will be when that happens. So here's an explanation of how to perform the test. Sit or stand with a hand behind the dorsal back spine and rotate. We did this the other day. So we don't need to go through that because we covered that. Speeds test, we looked at that. It's creating it's a resisted test where you're asking the client to extend the arm and you're placing a resistance on the wrist, and you're asking the client to flex. So the muscles, that's again a speeds test. Full-can test, we didn't do that as much as we didn't do that on the other day, but it's a fairly simple test. It's a resisted test. You're putting your hand on the client's shoulder, you're asking the client to extend the arm, and you're putting pressure on the arm to see if you can resist. And you can see that it's for the supraspinalis or the fossa scapula. What it does, it adducts the arm. Another area where the client may feel pain is the insertion point of the greater tubercle of the humerus, just in there, on the tip of the shoulder. Full can test. So this is just an extension of the full can test. This is an empty can test. Full can test is what we did before, where the hands are extended more than 45 degrees from the body. And you just do therapists from behind. I don't think is as effective. I think it's more effective from the front, especially if you have a male-female client. If your client's a female and you're a male therapist, this is a test that most women would not be comfortable with in that position. It's best to perform it this way. So we're looking at the resistance, we're looking at adduction of the shoulder, we're looking for pain and weakness, and supraspinatus disorder. We did the Hawkins test. This is just an explanation of what the Hawkins test, which we did. This is how to perform the Hawkins test. You see how the therapist is supporting the elbow and is holding the elbow up as you push down on the forearm. The shoulder joint, the impingement that particular test is looking at is the bursa. It's looking at the supraspinatus tendon and the shoulder girdle joint there. Nears test, we did that. So it's done from a sitting or a standing position. It's not an issue. This is how you perform the test. You are supporting the scapula, making sure that you're limiting the range of motion. Then you are lifting the client's arm upwards to see what the range of motion is and where the pain is. So if there's any pain, impingement of the bursalis. And this is more of what's going on with the resisted external rotation test. What that is looking for. We're looking for teres minor impingement or pain in the teres minor. The issue with knowing whether teres minor is that it's a very difficult muscle to find out. It's at the lower border of the scapula, or the lateral border of the scapula, at the superior end of that, and it's in the lower aspect of that particular ligament. If there's pain around there, Nal Shul is the needle that you'll be using. So when you palpate Nal Shul and if there's pain there, most probably that's teres minor. This is the resisted external rotation, and we're looking at, this is the degrees that we're looking at. And here's another way of doing the external rotation test. This is the apprehension test, where we're supporting the shoulder. You can see that. We're asking the client to try and pull the fist back towards the therapist, and the therapist is gently pushing forward. And again, that is to look at the stability of the shoulder joint. And as you can see here, this is what happens when you put the shoulder in that position. And this is an explanation of how to do the test. Okay, it's looking for the instability of the glenohumeral joint. So that's the humerus, that's the glenohumeral joint, just in there. The going back to the humerus almost rotates 360 degrees in that joint. So that's why there's so many tests in the shoulder to figure out what's going on. This is a relocation test. You probably won't be doing this test very often. You're asking your client to lie down, so you're placing you're flexing the shoulder, so you're putting pressure on the shoulder, and the elbows off the table, so you can gently push down and just see how the ligaments are holding the shoulder in stability. If it's unstable, the shoulder will pop out. If it's stable, there'll be tension, and you won't be able to. And the test will be quite strong. You won't be able to do that.
Henri,
Yeah.
I can see that we're going to be bumped out of the meeting in 5 minutes again.
Yes.
Because
I'll
I think
start again.
Okay, lovely.
Yep. So what I'm going to do is I will stop everything. Thank you for telling me. Okay. All right, so I'll go out and I'll come back in. Okay, we'll go and have a cup of coffee or something, or make yourself a cup of coffee and we'll come back in. Okay?
How long?
5 minutes.